Okay, so you've heard quite a bit about direct-acting antivirals over the last 2 days, and today you're going to hear more. And as you know, the good thing is that we're really advancing towards a cure. Actually, when you look at the data, we are almost there for most of our patients. And so today you will hear the 2 of the 3 ION studies being presented. ION is the oral fixed-dose combination of ledipasvir sofosbuvir with and without ribavirin. Here in the ION 2 is 12 versus 24 weeks of treatment experience genotype 1 infected patients. A study done by an international consortium, as are all these large phase 3 studies. The study design, as you can see here, is pretty straightforward. You have randomization into 4 groups. 12 weeks, one just a single pill, the other one together with ribavirin, and the same is true for the other 2 groups where you go for 24 weeks of treatment. Again, ledipasvir sofosbuvir in one group and the combination of it with ribavirin in the other group. It's a randomization of equal number of patients into each of the 4 arms, and as you can see here, those are treatment experienced patients. 53% failed prior triple therapy with a dual therapy plus also a PI. 20% of the patients had cirrhosis, compensated I should say, and 88% of those patients had an unfavorable IL-28B genotype, which, as we know now, probably has not much importance for these types of treatments anymore. Now, the story is actually very short, because when you see these figures, you know it works extremely well. Basically, you cure almost everyone. At least half of the patients that are not cured are lost to follow-up, meaning that the actual cure rates oftentimes are really higher. And you can see that even in treatment-experienced patients with genotype 1, it does not matter whether you add ribavirin or you don't add ribavirin. It doesn't matter whether you really go for 12 weeks or for 24 weeks. You will cure basically all of these patients. It's also independent of the subtype of genotype 1, genotype 1A or genotype 1B. They're both responding the same way. So this is all incredibly good results for these patients. The second trial that's being presented is the ION 1 study, which is basically the same trial design, except for it's about treatment-naive genotype 1 patients, so supposedly easier to treat patients, and again by an international consortium, this time led by Alessandra Mangia from Europe, so we like to point that out specifically here, and Alexandra is here. So trial design is exactly the same as it is for the ION 2 study. The difference is that you have treatment-naive patients with genotype 1 and have broad inclusion criteria. Again, patients with cirrhosis were included, no limits on age or body mass index, and no upper limit, I should say, because children were not included, but platelet count above 50,000. So again, this is actually quite liberal compared to the previous studies that we did with interferon ribavirin. No neutrophil minimum. There's also no reason for that. And as you can see, this was a larger trial. The other one had 440 patients. This one has over 800 patients. And in the analysis, there was a substratification into the genotype 1 subtype and also cirrhosis. But as you will see, this really does not have a lot of meaning, because the data are very, very convincing and almost unbelievable, too good to be true. You can see that in this trial, the lowest cure rate is 97%, and it goes up to 99%. So irrespective of whether you go for 12 or 24 weeks, irrespective of whether you use ribavirin or don't use ribavirin. So here you basically, those patients you will treat with 12 weeks without ribavirin, or as you saw in the ION-3 study, probably even only for 8 weeks. Now, what goes along with these trials is this presentation here, because when doing the phase 3 program, part of these studies was also looking into the quality of life of the patients. So you get here from the ION-1 trial the results of the patient self-reported outcomes during treatment. And since you know that this was quite of a problem with the interferon-based treatments, you'll be pleased to see what you see here. But also, I think in the design, this was important because now we know that you don't need ribavirin. So you might argue that this is really not that much of importance, but it could have been that in the phase 3 trials, ribavirin would have added a benefit. And then, of course, this would have been counterbalanced by maybe reduced quality of life. So what you see here during the 12-week arms of ION-1, the patients received questionnaires, several one actually, SF-36 as the best known, and then several other ones, and they received them 7 times during the course of the treatment and also during follow-up. And the outcome here is what you see. Actually, in SF-36, there was not really a big difference. In some of the other ones, especially when you look at fatigue, which is aggravated by ribavirin, you can see that the ribavirin-free regimens are doing better. And also when you look at work productivity and activity at work, it's better when you have more hemoglobin, then you're more active, and therefore ribavirin-free regimens are of advantage here. But again, since the data now show that you don't need ribavirin, we're not going to use it. So this is just to put it in context. The ION-3 study has been presented, I think, yesterday, where the fixed-dose combination of ledipasvir and sofosbuvir with and without ribavirin was tested for 8 versus 12 weeks in treatment-naive non-cirrhotic genotype 1 patients. And this trial had 3 arms, the 8 weeks of ledipasvir sofosbuvir, 8 weeks of ledipasvir sofosbuvir and ribavirin, and then 12 weeks of ledipasvir sofosbuvir. Again, randomized in a 1-to-1-to-1 fashion. And here again showing that the worst you can get is 93% cure rate, up to 95%. And I'd like to mention that 1, 2, 3% off usually does not indicate anything. It does not mean that this is less effective than the ION-1 study where you see 99%. It's just you lose a few patients to follow up, and it's basically the same effectiveness. And 8 weeks for the genotype 1 naive patients seem to be enough, even without ribavirin here. Okay, so this here is a study with different compounds. Yesterday, if you were here at the press conference, Alessio Agemo presented the data of the Sapphire studies and also of Pearl. And here this is a study also of the AbbVie compounds, interferon-free regimens of ABT450, dasabuvir and ombitasvir. I still have to get used to these names. We used to say ABT333 and ABT267. So in liver transplant recipients with a recurrent HCV genotype 1 infection. So of course this is an important group of patients because after liver transplantation you have more rapid progression of fibrosis in the patients, in all patients, well, not in all patients, but all patients are reinfected, but the rate of increased fibrosis is higher. We estimate 20 to maybe 30% of patients that have significant fibrosis up to cirrhosis after 5 years post-transplant. So these patients are in a very high need of treatment. And it's important to show how the new drugs work in these patients. Not so much because they might not work, but of course liver transplant patients receive a lot of other drugs and there might be drug-drug interactions. And in particular with with ABT450, which is a ritonavir-boosted drug, a protease inhibitor, it is important to study what the real-life outcome also in terms of side effect is. So here, patients received the 3D regimen plus ribavirin for 24 weeks. It was a fairly small study, as you can see, 34 patients, and then with follow-up. And what you see here is again actually quite spectacular for a post-transplant setting, because as you can see, on treatment, all the patients responded and became virus negative. After the end of treatment, you had one relapse. It looks like 95%, but this is exactly one patient due to the small patient numbers here. And this patient had resistance-associated variants, but basically we can take care of post-liver transplant patients with these regimens very, very well, and again, tolerability was quite good. Adverse events were generally mild. 2 patients experienced serious adverse events, and 1 patient discontinued due to them. And there were no deaths, no graft loss or episodes of rejection. And the concomitant drugs that those patients need, like the calcineurin inhibitors, were manageable. And so I think that these data are very, very good and promising, that we will be able to take care of our post-transplant hepatitis C patients in a fantastic way, I should say. So the results of the ION studies demonstrated highly satisfactory cure rates with a fixed-dose combination of direct-acting antivirals, sofosbuvir and ledipasvir, among patients with genotype 1 HCV infection without the use of either injectable interferon or ribavirin, with cure rates well in excess of 90% with as little as 8 weeks of treatment for some patients. These data represent a significant advance in the race to develop a new all-oral treatment for hepatitis. And interferon-free regimen of ABT450, ambitasvir and dazabuvir plus ribavirin helped liver transplant recipients with cured HCV infection also achieve high SVR4 and SVR12 rates. So the other presentations that you will see today is about treating genotype 4. Now, genotype 4 is an important genotype, at least in Europe, I should say. It is, of course, the most prevalent or the only genotype you will see in Egypt. That's where it's most prevalent. But since and also other Arab countries, but those patients you can find in fairly large numbers in several places in Europe. You also can find them in the US. And therefore, treating genotype 4 is of relevance not only for Egypt, but also for other areas in the world. So here you see a trial of once-daily cimeprevir with PEG-interferon ribavirin in treatment-naive or treatment-experienced chronic HCV genotype 4 infected patients, and is a phase 3 trial, and you will see the SVR12. So included into this trial were patients that were treatment-naive, prior relapses, prior non-responders, could be null responders or partial responders. They were treated for 12 weeks with a triple combination of cimeprevir and PEG-interferon and ribavirin. And then, according to their response, if they were negative after 4 weeks, then the treatment-naive and the prior relapsers could stop already after 24 weeks, while all the non-responders and the patients that did not show such a rapid response would go on to 48 weeks of treatment. So here, those are the key results. Those are the SVR12 data, and as you can see, depending on whether the patients were treatment naive, relapsers, or partial or non-responders, you see different cure rates. But in the treatment naives, you get almost 83% SVR12. In the patients that were prior relapsers, you get 86% of SVR12. But in the partial responders, and especially in the null responders, you do lose efficacy significantly. For example, in the null responders, you only have an SVR12 of 40%. I mean, mind the small patient numbers, of course, a few patients more or less here make a big difference, so the figures could be actually slightly better than that. But what you see is in this PEG interferon ribavirin-based regimen is that prior null responders really don't respond that well with genotype 4, while naive and relapsers show very good cure rates even with genotype 4. Now, along those lines is this trial here, sofosbuvir plus ribavirin, an interferon-free regimen in the treatment of treatment-naive and treatment-experienced patients with genotype 4 infection. And here the study design was a two-arm design. It was randomized, open-label, single-center study. That's why you have this fairly small patient numbers, but at least 30 patients in each group. One group received sofosbuvir ribavirin for 12 weeks. The other group received the same regimen for 24 weeks. And then the primary endpoint was SVR12. Patients had to be born in Egypt, and both parents had to be of Egyptian ancestry. So the genetic background, at least, is fairly similar in those patients. 20% had compensated cirrhosis, and they could be treatment naive or treatment experienced. So here what you see is that contrary to genotype 1 with the single pill, in this sofosbuvir ribavirin-based regimen, treatment duration does make a difference, because both in the treatment naive and the treatment experienced patients, treating for 24 weeks is definitely better than treating for 12 weeks, with cure rates of 80% versus 100% for the treatment-naive patients and 60% versus 87% in the treatment experienced. You really see in treatment-naive patients, also with this sofosbuvir ribavirin regimen for 24 weeks, you can cure almost everyone. Again, mind the small numbers. Of course, this is only a phase 2 trial. So in a phase 3 trial, this likely looks slightly different. And in the treatment-experienced patients, you can still get 87% of cure rate, which is very good and compares very well to also the interferon-based regimens that I just presented before. So in summary, cimeprevir with PEG interferon ribavirin is effective and well tolerated in treatment-naive and treatment-experienced patients infected with HCV genotype 4. Positive results for the cimeprevir-based regimen are welcome, as HCV genotype currently has limited treatment options. And although HCV genotype 4 is mainly found in the Middle East, Egypt, and Central Africa, it has recently spread in several Western countries, particularly in Europe, with rates of 10 to 24%. And so also in our areas, it is important that we have develop treatment options for those patients. And of course, for Egypt, this is also very important.
Good morning, everybody. You will perceive some emphasis in this title, referring to the first phase 3 trial in 2 decades dedicated to primary biliary cirrhosis. And if you compare this situation with what we have just left, how many trials are ongoing, not in phase 3, but they will be available soon. As far as antiviral are concerned, you have an idea of how new treatments are needed in this field. And they are needed because we have a treatment, an established treatment, and in particular, a patient with primary biliary cirrhosis should be treated with ursodeoxycholic acid. As any clinical practice guideline is outlining. relatively high dose, 13 to 15 milligrams per kilogram per day. And we know that this treatment works because we have seen from previous studies and overall meta-analysis that the long-term effects of URSO in patients with primary biliary cirrhosis are there, especially in patients with an early disease. So when we are able to start treatment in the very in very early stages of primary biliary cirrhosis. Another problem with this disease that in general its progression is very low over the time. So we have in general to rely on surrogate markers. And so we are caring about the effects we are obtaining on biochemistry and to translate them on the clinical ground. But we know that there is an acceptable, a reliable relationship between the changes in biochemistry and actually the development of the disease. But anyway, this should be taken into account. The point is that a proportion of patients, relatively low, is not tolerating URSO, especially at these doses. And some of them are not showing improvement in biochemistry and therefore possibly in their disease. So we do need alternative treatments. And if we all agree that ursodeoxycholic acid is the treatment of choice for this patient, no consensus, we have no consensus on how to treat in patient. We have not a good response to URSO. Well, in relatively recent time, we have seen that the so-called farnesoid X receptor, which is a member of the nuclear receptor superfamily, once activated, once stimulated, influence many metabolic pathways, including that of the bile acids. It is expressed as, in many tissues, but mainly in the liver and the intestine, in the gut. And as far as the liver are concerned, the stimulation of this receptor regulates bile acid synthesis, conjugation and transport. And obeticholic acid, with is a semi-synthetic bile salt, with many structural similarity with the physiological chenodeoxycholic acid, has turned out to be a very potent and selective specific activator of FXR. And there were animal studies suggesting that the stimulation of FXR by obeticholic acid has a favorable effect in cholestasis and therefore could be used in patients with chronic cholestatic liver disease as primary biliary cirrhosis. And there we are. The POI study is a phase 3, double-blind, placebo-controlled trial exploring the effects of obeticholic acid administration in patients with primary biliary cirrhosis. Is a multi-center international trial. And this is the design. The obeticholic acid has been added to the current therapy in patients with primary biliary cirrhosis. Current therapy means use of desoxycholic acid, but we should also take into account that the number of patients included in this trial did not tolerate URSO or had not shown favorable result under URSO. So in a certain number of cases, obeticholic acid was the unique treatment. One arm received placebo, another arm obeticholic acid, 10 milligrams per day, and there was also a, I would say, titration arm, starting with 5 milligrams per day
then after 6 months to 10 milligrams per day. And then all the subjects were included in a long-term extension of the study. And these are the main results. I would like to draw your attention as the primary endpoint. And we know when I told you about the correspondence between biochemical changes and clinical development of the disease, we have some endpoint to be reached by the treatment in order to be relatively sure that the effect is translated into the progression of the disease, and namely, it refers to alkaline phosphatase serum level, which are below 1.67, the upper normal limit, or anyway obtaining a reduction of at least 15% with respect to baseline values, associated to normal bilirubin levels. And we can see that these endpoints with placebo were reached in less than 10% of cases. And with the 10 milligram regime, we had at least 50% of patients reaching this endpoint. And with the titration arm, we see once we reached 10 milligram in patient who need it, again we reached about 10% of success rate. And this is the changes in alkaline phosphatase versus time from baseline. And you see this is the placebo arm, this is the add-on titration arm, and this is the 10 milligram arm. So, I mean, a fairly high rate of response, taking also into account that we are dealing with a certain number of patients who didn't respond to a previous treatment with ursodeoxycholic acids. And these are the main conclusion. Obeticholic acid given to patients with primary biliary cirrhosis with an inadequate response to urso or are unable to tolerate it, produce clinically and highly significant meaningful improvement in liver biochemistry, shown to be strongly correlated with clinical benefit. Apart from pruritus, and if you recall what we discussed in the first press conference, pruritus is the main side effects of this drug. Apart from pruritus, the incidence of the adverse side effects was generally similar across both obeticholic acid groups and placebo. And pruritus, generally mild to moderate, was the most frequent reported side effects. And starting patient with 5 milligram of obeticholic acid and titrating it to 10 milligram if needed appears to be the most appropriate dosing strategy for the time being, at least.
Good morning. Hepatocellular cancer is one of the commonest causes of mortality. The World Health Organization have reported this year that in 2012 it was the second commonest cause of cancer mortality, accounting for 800,000 deaths. Now, the majority of those patients die in the year that they present, and that's because they present too late for us to be able to treat them effectively. Now, I hope that in years to come, one of my follow-on people from the governing board presents big trials like we've seen today on hepatitis C, showing a major impact on mortality for patients with liver cancer. But today, the studies that we're going to highlight are those that really underline the importance of early detection and screening and staging of the cancers in order to impact mortality. The first study is from Philip Johnson's group in the UK, and he's got together with some of his colleagues around the globe and studied very large cohorts of patients with liver cancer. We can see them listed there. These are patients from the UK, Japan, Hong Kong, and Spain, where the incidence of liver cancer is different. It's high in Japan and Hong Kong, where the prevalence of hepatitis C and hepatitis B is high. In Spain and the UK, it's much lower. But they've compared all these variables shown on the side, including age, gender, the etiology of the disease, the stage of the tumours at presentation, and they've also looked at whether or not there was a screening program in that country where the patients have presented with cancer. And the data really are very striking. So we're looking here at a survival curve in each of these countries. The best one is the one on the top, that's from Japan. And for a patient presenting in Japan with liver cancer, we would expect, you can see in the table at the bottom, that the median survival is 47 months, so that patient might expect to live for 4 years. And in Hong Kong, that's just 7 months, and the UK and Spain is somewhere in between. Now, Professor Johnson and his team have looked at these patients carefully, and what they've shown is that in Japan, the patients are detected at a much earlier stage, and that means they can be offered curative therapy. So to look at this slide very quickly, Professor Johnson's going to present this in 15 minutes in the plenary session. But if you just look down here on the bottom second row up, Japan 1975 to 1985, the median survival in Japan was just 7 months. And in the top panel just here, that was survival in that time period in Japan. And what's been done in Japan is the introduction of a very intensive screening program with ultrasound for patients who have hepatitis C. So they're the patients at risk of getting liver cancer. And if you screen them with ultrasound to detect the cancer and you get it early, you can treat it effectively. And so the implication here is that in those other countries where we're not doing that, if we did do that, we may also be able to increase the life expectancy of patients presenting with hepatocellular cancer. Now, this is moving on to a study from the Asan Medical Center from Seoul in Korea, where the staging of the liver cancer at the time of presentation is shown to be very, very important. Now, these are patients that have been detected at a relatively early stage, but we know that early recurrence in patients that receive curative therapy is high, and that if people get early recurrence, that's associated with a poorer survival. Now, the team from Korea have considered the hypothesis that actually it's not early recurrence, it's cancer that was always there. We just didn't detect it at the time we gave the patients their first treatment. So they've taken a large group of patients, 700, who had a single cancer diagnosed by a combination of ultrasound and CT scanning, but nearly half of those, 323, had an extra scan, and that's with magnetic resonance imaging and gadoxetic acid. The gadoxetic acid is a contrast agent which improves the sensitivity of cancer detection. And what they've shown is that if they did that, they detected additional nodules that weren't seen by ultrasound and CT in 53 of the 323 patients, and that changed their staging. And the team will be able to tell us in the parallel session this afternoon what they did to those patients, in addition to those that had the CT scans. But by knowing that they had more disease at the beginning and treating them more effectively, you can see that they've actually reduced recurrence in those patients here with a hazards ratio of 0.72, and that translated to an improvement in survival with reduced overall mortality. And so they've concluded that staging with this more sensitive method at the time of diagnosis is very important and can improve survival. Now we're going a step back here, and this is an innovative study from Singapore, from Professor Hui's group, and they're looking at the ways that you might detect cancers earlier, so how to improve screening. And this slide from Professor Hui is summarizing ultrasound here in this panel, which is what's been used very effectively in Japan, where the sensitivity is very good, but actually in other parts of the globe it's not very good. And that's perhaps because the patients have a scarred, lumpy liver, the ultrasonographer perhaps isn't as experienced, and maybe the patient's shape is different. So in some places, the sensitivity of that technique is as low as 30%. So we need something better in areas where cancer isn't so common. We're now on the other panel, we're looking at alpha-fetoprotein. That's a serum test. It's been widely used, and it's a protein produced by the cancer cells, but only ever in up to 60% of the cancers, and only at an advanced stage. So actually, as a screening tool to detect early cancers, it's pretty hopeless. And so what Professor Huey's group have done is they've gone back to blood, but they haven't looked at serum, they've looked at the white blood cells. And these are the cells that are part of our immune system. They respond to infection. They also respond, we think, to tumours. So there might be changes in those white blood cells in people's blood there because they've developed a cancer. And so he and his team have studied patients with hepatitis B. They've used a gene profiling technique to identify changes in white blood cells in their blood to see if something changes when the patients develop cancer. And they've come up with 3 genes, which are named on the next slide, and they've developed a 3-gene test. And then they've gone back to their own patients and they've compared bigger groups of nearly 200 patients in each, in which half the patients had hepatocellular cancer with hepatitis B and the other half didn't have cancer, but they had hepatitis B. And so this is the name of the genes. They're not particularly relevant to this presentation, but in combination, what's important is that their expression changed, and if you use them all together, the sensitivity of that gene signature in these patients with hepatitis B for detecting their hepatocellular cancer was 88%, and that's up there with ultrasound being performed 3 monthly in the Japanese patients. It's excellent. In the same group, alpha-fetoprotein sensitivity was very poor. That perhaps suggests that these were patients with early cancers, but he'll be able to address that later on this afternoon or perhaps after the presentation. Now we move on to 2 presentations on a treatment with radiofrequency ablation. Radiofrequency ablation is where a needle is inserted into the tumor. Radiofrequency waves are passed down the needle that generates heat at the end of the needle and burns the tumor around it, which is the tumor. Now, this is something that's been used for a number of years. The curative treatments are considered to be resection and transplantation, but what we're seeing here in a large group of patients, 837 from the group here in China who've got hepatitis B, is that these were patients who had less than 3 tumors, less than 3 centimeters, treated by this method. And they're showing here the long-term survival. So this is important. At 1 year, over 90% of the patients were alive. That's over on that side. At 5 years, over half the patients were still alive. This is recurrence-free survival, showing that some of them had the tumor had come back and they needed more treatment. But importantly, at 10 years, a third of the patients were still alive. And that's encouraging when you have the patient in front of you and you're choosing the treatment for them. And this is just showing you that in sub-analyses, it was the patients who had a single tumor that you could predict better survival, and also those that had preserved liver function, which you would expect. So this is encouraging. Now then, the final study is a much smaller one, and this is from Naples in Italy, where they've looked at using radiofrequency ablation in a group of patients where it's not normally used. These are patients with a main portal vein thrombosis. When you stage a person with cancer, you're looking to see how many cancers they've got, the size of their cancer, has it spread outside of the liver, and also if it's invaded the main portal vein that brings the blood from the bowel into the liver for cleaning really before it goes around the body again. And then if your portal vein is invaded with tumor, it's a very poor prognostic factor. You can't cure the patient anymore. You can't remove that vein. You have difficulty treating the tumor in another way in case you actually compromise the blood supply to the liver and cause liver failure. So this is a courageous study really, where they've identified a group of patients between 2005 and 2012. So out of a very large group, they've identified over 700 who had a cancer with a main portal vein thrombosis, and a small number that had just one cancer, less than 5 centimeters, where there was a main portal vein thrombosis. So you want to treat them if you can. And they offered those patients treatment with radiofrequency ablation, but the difference was, and they could explain this in more detail, they also treated the tumor in the portal vein with this technique, which is novel. Now, the bottom line here is that in the 22 patients which declined this treatment, that formed the control group, as you would expect, none were alive at 1 year. But in those that accepted the treatment, and they'll have to tell us more about the complications or how they did it, but basically at 1 year, 62% of the patients were still alive. Nearly a third of the patients were still alive at 3 years, and amazingly, really, there were still long-term survivors at 5 and 7 years, which is something that can offer hope for this group of patients that up until now we haven't been able to really offer that. So in summary, what we've shown is that early detection and screening are of paramount importance for for these patients, because we have to identify the tumours earlier if we're going to offer more effectively the treatments that we've got. Very exciting is the 3-gene signature suggested by Professor Huey's group. That's something that perhaps we could apply to patients with other risks for developing liver cancer, developing sensitive tests outside the setting of hepatitis B. And then I've also shown 2 studies highlighted here at this meeting looking at radiofrequency ablation as a treatment, both offering long-term survival for patients in whom we tend to use it, but also perhaps its use as a treatment in those with more advanced disease. Thank you.